matter whether it's oxygenated or not oxygenated. That doesn't matter. The only thing that matters is which direction is it's going. If it's leaving the heart, it's an artery. If it's coming back to the heart, it's a vein. Now, the primary example of the problem there is in the pulmonary artery. The pulmonary artery is the big artery that leaves the heart and goes to the lungs. It's leaving the heart, so it's an artery, but it's totally blue blood. It's totally unoxygenated blood in the pulmonary artery. And that's really the only one that happens with. After blood flows through arteries, it passes through arterioles. And arterioles are very important, as we'll discuss, because arterioles really control where blood flow goes. They have a lot of muscle in the wall of them, and they kind of decide, under control of the autonomic system, where the blood is going to go. If you're in fight or flight, it's not going to send much blood to the kidneys, for example. You don't need to be making urine when you're trying to fight the tiger. And so that's the most important point to know about arterioles. We're going to go through them again, but just know that that's really these are the controllers of blood flow. And then the capillaries are really where all the action happens. The blood goes out and gets smaller and smaller and smaller and smaller until it's in capillaries. Capillaries, by definition, are one cell layer thick in the wall. It is simple squamous epithelium. It's called endothelium. Endothelium means the epithelium on the inside of the blood vessels. It's also the lining of the inside of the heart as well. And even though the aorta and some of the big blood vessels will have lots of layers to them, the innermost layer is always endothelium. It's always simple squamous epithelium. The capillaries are really where things happen. It's where all the exchange happens. And really that's the reason we have a cardiac system, right? It's to carry oxygen out. It's to bring waste products back. And the best way to, the way the body gets rid of the oxygen out of the blood vessels and out of the blood is to run it through the capillaries, which are only one cell layer thick. There's a capillary very close to every cell in your body, and they will then exchange. The oxygen will go out, carbon dioxide will come in, sugar will go out, waste products, urea and stuff will come back into the bloodstream. Venules are little bit bigger veins, and then big veins are what return the blood to the heart. And like most everything in A&P, it seems like they have three layers. There's a tunica intima, it's intimately in touch with the blood. It's also always simple squamous, like I just mentioned. There's a tunica media, and the tunica media can be very, very thick, especially in big arteries like the aorta. You know, the aorta is about this big around, big as $50 probably, and it has very thick walls, and those walls are elastic, and they expand with each heartbeat and then contract back down. If you ever get a chance to see heart surgery or aortic surgery in the abdomen, you can just absolutely see it pulsing away. And then there's the tunica externa. The tunica externa is the outermost layer of the blood vessels. In some blood vessels that's very important. Most blood vessels it's not. It's generally not. It's not a huge layer. We're going to put our time into the intima and the media, I'd have to say. So, going back through them, the intima is the innermost layer. It includes that endothelial lining. There's a little bit of connective tissue, and it also includes this thing called the internal elastic membrane. And it's a layer of elastic fibers that are found in the outer edge of the tunica media. In other words, just underneath the innermost layer, you'll see this layer of elastic tissue, and it's squiggly. You'll see it under the microscope here in a second. The tunica media is the middle layer. It's concentric layers of smooth muscle with a bunch of connective tissue in it. It also has an elastic layer as well, and this one is called the external elastic membrane. So just remember that the internal elastic membrane is in the intima, and the external elastic membrane is in the media. And the external elastic membrane is the last layer of the tunica media and separates it from the tunica externa. The tunica externa is really just adventitia. You've heard that word before. It's just kind of a connective tissue that kind of gloms around the artery and forms the outermost layer. One thing that's interesting about the tunica externa is it does have some blood vessels in it. And the reason is because the largest blood vessels, like our aorta, are thick. And they can't just, you can't diffuse oxygen from the inside of the aorta all the way out through all the layers of the blood vessel. So we have these things called vasa vasorum, which are blood vessels that actually carry blood into the wall of the aorta. Because it's thick, it needs vasa vasorum to carry blood into the wall of the blood vessel in order to keep it alive and keep it nourished and keep it healthy. You only find these in the large arteries and in a few of the large veins, and their whole purpose is to supply the cells of the tunica media and the tunica externa, the layers of the blood vessels, with oxygen and so forth. So here's kind of what they look like. I think this schematic will really help you, but you need to look at these over in the lab. You don't realize it, but you've been looking at arteries and veins on every microscope slide you've ever looked at, because every microscope slide we've got over there has got a blood supply to it, and so there's arteries and there's veins that are on it. You probably didn't think about them. You thought, oh, that's just another tube, and I don't care about it, and that's fine. But now's the time to take a look at some of them. And we even have slides that are labeled blood vessels. Isn't that lovely? And a couple of points here. So here's the artery. Here's a thick artery. It's got the inner layers, the endothelium, which is that one cell layer thick squamous cells. Below that's a little bit of connective tissue. And then here's the squiggly layer, which is called the internal elastic membrane we just mentioned. So those two layers make up the purple layer here, and that's the interna, the intima, tunica intima. The next layer can be really thick, just so you know. It's the tunica media, illustrated in pink sort of here, or pink or orange, whatever that is. And you notice that it has lots of elastic fibers scattered through it. The external elastic membrane is seen right here. This is just elastic fibers on the outermost layer of the media. It doesn't really show up very well on this, and I think it will show up better actually under the microscope. You should be able to see a distinct layer of elastic fibers there in the externa. Excuse me, in the external layer of the media. Right? This is the media. And then the last layer is this externa, which consists of more muscle fibers, more elastic fibers. It's kind of it's not all that organized. It's an adventitia, and which just means a collection of connective tissue. So there it is. There's the three layers. I think the most distinctive layer that you can see under the microscope is this internal elastic membrane, this squiggly one, because when you see that, you know you're looking at an artery. Okay? The other clues here are that arteries tend to be round. They're under pressure. They have all these layers that we mentioned. You can see how thick the wall of this artery is, and notice that it is round. It's always smaller than the veins. Why? Because the pressure is so much higher here, and these things are flowing so much faster. So the veins can be bigger because they're just sort of, the blood is just sort of sitting there in them a lot of times as it collects to go back up to the heart. Notice that the lumen of the vein is a lot bigger, like I just said. Notice that the wall isn't near as thick as the artery, and notice that they just assume the shape of the tissues around them. Because the veins are under low pressure, muscles and connective tissue that's around the veins can push on it and change its shape. And so, as a result of that, the veins kind of, fill the space as well. And things fit in around them very nicely. Let's talk about vasoconstriction and vasodilation. You guys know probably what those terms mean. Vaso just means vascular constriction, and vasodilation means dilation of the vessels. I think the best example to present for that is your face in very cold weather. If the weather is very cold, the blood vessels in your face, if you're outside, are going to be very vasoconstricted. And so if somebody looked at your face, you would probably look rather pale. And that's because the arterioles are saying to the bloodstream, we don't want to send a whole lot of blood to the face, because if we send a whole lot of blood out there, it's going to get cooled down really cool, and that's going to be a problem with our thermoregulation, and we could even become hypothermic. We could get cold. So our body compensates for that and vasoconstricts the vessels going to the skin. Just the opposite happens if it's summertime and you're out running and sweating and you need to get rid of heat, and you look at somebody's face, it's probably going to be flushed and red, because in that case the body is going to say, hey, we need to percolate as much blood through the skin as we can so that it can release the heat and keep us cool. And also, by the way, while we're out there, let's send messages to those sweat glands. You remember those eccrine sweat glands that we learned about back in 231. We're going to make them sweat, and that's going to allow more heat to evaporate with the sweat. Obviously, if you're completely vasoconstricted and all the blood vessels in your body are vasoconstricted, which happens when you're in fight or flight, that increases the afterload on your heart, and it makes your heart work harder because it's got to push it in to a system where all the pipes are small. And of course the heart would rather pump the blood into pipes that are wide open, ready to receive it. It's also obviously going to affect the capillary blood flow, and I think I just gave you a good example of that in the skin. So arteries there's actually several types of arteries that your book talks about. I'm not so sure. You're not going to be asked to look at an artery and say, is this an elastic artery, is this a muscular artery, or is this an arteriole? That's really splitting things too far. But I think you should know these characteristics of vessels as they go from bigger to smaller. First of all, when arteries are really big, and I'm talking about arteries as big as your radial artery, which is the one you can feel in your hand down here. Everybody feel their pulse on their wrist over on the thumb side, right there. You see, that artery is stretching with each heartbeat and collapsing. So you know that is an elastic artery. Now beyond that elastic artery, there's going to be smaller muscular arteries and then smaller arterioles. The biggest example, obviously, of an elastic artery is the aorta that I mentioned before, which is huge. Arterioles are getting pretty small, and I wouldn't want you to memorize any millimeters or micrometers as how big they are, but just know that they gradually get smaller and smaller, and as they get smaller, we call them muscular arteries, and we call them arterioles. And because of that, because these arteries have a lot of muscle fibers in the walls, they can sort of act as the gatekeepers to either allow blood to flow into a certain vascular bed, for example, your skin, or not, based on the conditions. If they're constricted, they oppose blood flow, and that increases the resistance. We're going to talk about blood flow, and when we talk about blood flow, we're going to use terms like, cardiac output, which we already talked about in the heart chapter, but we're going to talk about cutting down on blood flow to one area or another and opening up blood vessels to one area or another. Now, I think one thing that I always had a hard time understanding about this is this thing called resistance. And the arterioles are really the resistance vessels. They're the ones that clamp down to close a region off from blood flow. Now, there is no way to send more blood to a certain area other than to relax the resistance vessels, to open them up. There's not like a special pump out there in the periphery somewhere that's going to say, hey, we need more blood flow to the skin, let's turn on these skin pumps. It doesn't work like that. It's all one pump, that's your heart, and you have these resistance vessels that then can relax or contract in order to send blood to one place or another. Okay? An aneurysm is a bulge in the arterial wall. I thought repairing aneurysms was a lot of fun. It's a really exciting case. And most aneurysms occur in the abdomen, abdominal aortic aneurysms. So if this is your kidneys on either side, 98% of all abdominal aortic aneurysms begin below the renal artery takeoffs, which is nice because you can clamp it below the renal arteries and not have to cut off the blood flow to your kidneys even for a minute or two. And then the aneurysm starts here and it bulges out like this, and it may extend down onto the iliacs down in the lower part of your belly where it splits to your two legs, but it may not. And so the treatment of this is to put a clamp on here, put a clamp on there. Patients on blood thinners, heparin, make a big incision down the aorta, lay it open. There's always going to be some little iliac arteries, or not lumbar arteries, coming in from the back. And if any of them are still open, and sometimes they're already all clogged just because of arteriosclerosis, which is the cause of these aneurysms. The arteriosclerosis weakens the wall and they bulge out like that. Anyway, so then with the artery open, you've opened it out like this. You sew those over. And then you take a piece of Dacron tubing. You kind of look at it and say, okay, we'll take the 24 millimeter one. And maybe sometimes we even used a ruler and measured to see about how big it was. But anyway, you sew this tube in, and you sew it in at the top, and you sew it in at the bottom, and that becomes their new aorta. So you've just got two suture lines there, and they've got to be watertight, obviously. And then that old floppy aorta that you just opened up, you just usually just pull it back together and let it lay there and stay there the rest of the person's life. But now the blood is flowing through this Dacron tube, and that Dacron tube is pulsing with every heartbeat, as opposed to the aneurysm pumping with each heartbeat. And the problem with aortic aneurysms is they get bigger as time goes by. So in general, if you feel one and you get an ultrasound and measured, and if it's less than 5 centimeters, we usually ignore it and tell them to come back in another year and we'll check it again. If it's 5 centimeters in size, which is about that big, then you repair it. You tell them that the odds of the chances of it rupturing on you are getting high enough now that it's worth taking the risks of surgery. The risk of surgery is about 3% probably, and the risk of rupture once it gets to that size is probably 1% a year. So in 3 years it's probably going to rupture, and also it's going to keep getting bigger, and the bigger it gets then the quicker they rupture. So that's what an aneurysm is. They can occur in different places. I think we talked about aneurysms occurring up in your circle of Willis, in your brain, right around the base of your pituitary gland, your infundibulum, and where the blood vessels meet up there. Those aneurysms are just clipped. They aren't replaced like this one is here. Somebody in here know somebody with Marfan syndrome? Okay. Somebody was talking to me about that the other day. So here's kind of a review slide that kind of puts these all together. And obviously the big elastic arteries, as illustrated here, are the ones leaving the heart, and they're coming down here. And when they get pretty small, they become muscular arteries. You notice that they have a lot of nothing but muscle in the wall, really. And then as arterioles, they get smaller and smaller, but still have plenty of smooth muscle, because these are the ones that control the flow. These are the doorkeepers, the arterioles. And then you get into capillaries, and capillaries can be of several types. And then they start getting bigger and form veins, venules, medium-sized veins, large veins, and head on back up to the vena cava and back into the heart. Just a quick word about these two lowest pictures here. We have several different kinds of capillaries. For example, in your kidney, you have capillaries that are made to just allow the water to kind of flow out of them and filter the water, because that's what kidneys do. And then in other areas, they're continuous and nothing leaks out of them. You probably wouldn't want a lot leaking out of the arteries out here in your fingers or in your skin. But in certain organs, especially, another one is the liver, and another one is the bone marrow. Remember the way bone marrow works, the blood just kind of dumps into the bone marrow, and it percolates up and down through the bone marrow, and then it's collected back into veins and gets back into the circulation. Did we talk about external osseous infusions? For those of you that work ambulances, the New Deal, it was just starting when I retired back at the turn of the century. That sounds so long ago. 2001 was the last year I practiced. When kids are injured and when they're in an accident and so forth, it's very, very difficult to start an IV on them, to give them IV fluid and so forth. And so a technique has been developed where you take a little Black & Decker drill, basically. You guys do these?
We don't have the drills, the firefighters do, so we do.
You just twist them in? Yeah. You basically take either a little drill and drill a tiny hole right into their shin, right up front here, right through the bone, into the bone marrow. Take the drill out, put a needle in, the needle goes directly into the bone marrow, and then you can just pour fluids into the kids. And it percolates through their bone marrow, and then it percolates out into their veins. And you can give them blood, you can give them albumin, and you can give them IV fluids, you can give them everything right through that. But that's a pretty good example of a place where there are fenestrated capillaries and where the blood just kind of flows out into the bone marrow. Pretty cool. I've never seen one done. They were just starting to hit the ambulances out in the Dalles when I called it. Just for a minute, let's talk about arteries, because this is the largest disease in America. This is arteriosclerosis. And what arteriosclerosis is a buildup of fatty deposits, cholesterol mainly. That's why we take our Lipitor and our fat-blocking drugs. This is this would be a normal artery, except it should be about this size right here. But you notice that there's all of this crap has collected in the wall of the artery and kind of bulged in to the artery and causes this now, instead of being 100% open, now to be only like 25% open. And trust me, these can get down to 1% open. And a lot of people are walking around with a lot of their arteries at 1%. It's always amazing to me when you do an arteriogram on somebody who comes in for chest pain and you're looking for narrowings in their coronary arteries, the blood vessels that carry blood to the heart muscle itself. You might find 6 or 7 areas where it's 5% or less open. And those are the patients that are going to get bypass surgery around those blockages. So this is a microscope slide of the same thing as this is here. This is what it looks like. And you can see it's just white, fatty stuff that builds up in the wall. So as you get a little bit older, but not too much, get your cholesterol checked. And if they recommend you take an anti-cholesterol drug, by all means take it. I was driving in this morning, I was driving down Highway 26 out there, and there was an article on OPB about a guy who had analyzed the value of statin drugs, that's what they're called, is statins. And they're not only valuable in people that have high cholesterol, but they're probably even valuable in people with normal cholesterols, because it prevents the early stages of this, it prevents high blood pressure, it extends people's lives. The trouble is, of course, statins are not exactly cheap, but I take mine every day, and I bet a lot of your parents do as well. Yes?
I didn't realize that it was built up in the actual wall.
It's a buildup in the media. We just talked about the 3 layers. Yes, it's a buildup in the media of the wall.
Okay, so then how do the heart attacks happen? They always explain it, of course, overly simplified, that the plaque breaks off from the inside of the vessel.
Yeah, let me kind of draw a schematic for you. It might help better. If I can't find a pen, I'll just draw on the wall up there.
I have markers too.
Okay, I'll take one. Gosh, there's not a single one in here. I usually have a bunch in here too. Let's see what I do. Yeah, here's one. Okay, so if you look at the wall, and I will show you guys a video about heart attack here in the next few days that I think will also help you understand this. So here's the wall, here's the intima here, and let's just say that the intima, there's a big bulge of plaque. This is plaque right here, and so this side doesn't have so much. Okay, so this is plaque, this is plaque, this is the lumen where the blood is flowing through. It is true that a lot of times the thing just completely gets narrower and narrower and narrower. But in reality, what really happens is there's little collections of platelets that start to collect right here. And a little clot forms, and it goes on downstream and blocks off blood flow to a certain area of the heart muscle. There's also a thing that happens over here. You got blood flowing past here, and a little piece of this plaque rips, and so it lifts up a little bit, like that. And now the blood flows in there behind it, and the blood just continues to push that plaque off until the plaque completely occludes it and causes that whole blood vessel to be occluded then at that point. So it is a problem with the plaque, a lot more than the platelets, but both of them occur when the artery is getting pretty thin. And the problem with this much plaque in the wall is that this intima isn't getting good blood flow, from those vasa vasorum. So this intima is kind of sick, and it's waiting to die and break off. Okay, so we're going to talk about capillaries a little bit more here, it looks like. Capillary structure, remember that the capillary is really nothing more than just an endothelial tube. That's all it is. There's a little bit of a thin basal lamina outside of those simple squamous cells, but that's it. Notice there is no tunica media, there is no tunica externa, and the diameter of capillaries is very close to the size of a single red blood cell. Well, you've looked at red blood cells under the microscope, and they're pretty damn small, and basically they have to line up one by one to get through most of these capillaries. And you also remember that thing called a rouleau, where the red cells would kind of form little stacks, and they could also bend me, shape me, in order to work their way through the little tiny capillaries. Most capillaries have a continuous endothelial laying thing, and all the tissues of our body have continuous capillaries. There are some things that I mentioned, like the liver, the bone marrow, where they're not continuous and the blood kind of just pours out. The thing about these continuous capillaries is they only want to allow water, small solutes, and lipid-soluble materials to go out. You do not want your blood cells to go out through the wall of your capillaries. Does that make sense? You'd like for your blood cells to stay inside, and you don't want your plasma proteins going out of your blood vessels either. Plasma proteins form a major part of the osmotic concentration of blood. And of course, osmotic concentration is normally about 300. You may not remember that much from 112, but believe me, you will know it by the end of 233. But we need our plasma proteins in order to keep the blood and the fluids inside of our blood vessels. If we don't have enough osmotic pressure inside the cells and are inside the tissues, then the water can't stay in as well, and we get real swollen. That's called edema. I think we've talked about that. We have special places up in the brain and the thymus. One of the examples is the blood-brain barrier that we talked about. It kind of protects the brain against abnormalities of the blood. Fenestrated capillaries are these ones that have all the leaks that are made to leak. Choroid plexus, remember that's where CSF is made. Endocrine organs have to be able to leak in order to let the big proteins, the big hormones that they've manufactured get out. We filter our blood, and in order to do that, we let a lot of water filter out through the walls of the capillaries in our kidneys, and a lot of water we let leak into our intestinal tract and mix with our food, and so forth. You'll learn more about those things when we get to the digestive and renal systems. And then there's these other places. I guess I kind of put the cart before the horse here a little bit. And they're really called sinusoids. That's where things just dump out into free spaces. And that would include things like the liver, the spleen, the bone marrow, and a lot of the endocrine organs. They're really bloody because they're just full of blood, because the capillaries in those organs just allow the blood to kind of flow out into the tissues. And then the tissues can take whatever they want out of it. But these spaces here allow for this free exchange of not only water but also plasma proteins and so forth. There's always phagocytic cells around. You know, a number of our white blood cells that we talked about last chapter are phagocytic. They eat things up. And that's certainly true at these sinusoidal areas like the bone marrow and the liver and so forth. We have lots of phagocytic cells to eat up anything that shouldn't be there. I don't really like